Today we have the privilege of having Dr. Peter von Dadelszen with us. Dr. von Dadelszen is from the University of British Columbia. His career has really been marked by the study of pre-eclampsia. He's a member of the Pre-eclampsia Foundation. He's doing extensive work both locally and internationally in the area of pre-eclampsia. Welcome, Peter. So, Peter, your career has really been focused narrowly on pre-eclampsia. I was wondering if you could tell us how you got interested in pre-eclampsia and how this course has led throughout your life.
So I became interested in pre-eclampsia early in my training in obstetrics. In fact, in the first few months, with a sentinel case of a woman who became very sick, and then if I bumped into her a few weeks later, and here was this, a woman who'd been on dialysis for 48 hours. And then a few weeks later, I bumped into her on the main street in Dunedin, in New Zealand, where I started my training, and she was this fit, healthy young woman again, and I wondered what had happened to her. I suppose I'm still wondering. And so I became interested in the disease process of pre-eclampsia and ended up getting a training position at the University of Oxford and doing wet lab research in the area of pre-eclampsia and looking at pre-eclampsia as essentially a form of systemic inflammatory response syndrome, and which gave me new sort of more insight into maybe how to monitor women with pre-eclampsia as more of a systemic condition rather than just being hypertension and proteinuria and maybe some liver problems. And that took me into wanting to do outcome prediction in women with pre-eclampsia, which we've been doing for a while. And then I don't know when it came to me that, in fact, well, that's fine and dandy for people like me living in Canada as I do now, or my colleagues in the States or in Europe or in Australasia, where we have all the bells and whistles of healthcare. But what about the 99% of women who die from pre-eclampsia in low and middle income countries? So we then transitioned the program to actually repeat the same process for women in low and middle income countries to identify those women who are at greatest risk for adverse maternal outcomes once they have the diagnosis of preeclampsia. So not trying to predict preeclampsia, but the complications afterwards. And that led into a whole line of research, and through that came to the attention of funders and have now sort of expanded out into a broad objective, which we call PREEMPT, which is the Pre-eclampsia, Eclampsia Monitoring, Prevention and Treatment Initiative, where we're trying to look at prevention and monitoring and treatment primarily for women in the community, so that we can initiate care, evidence-based care in the community, and get women to hospital quickly so that they are at the less unwell and can be salvaged.
So you've talked a little bit about the developing world versus the developed world. Could you share with us what the disease looks like in the developed world, underdeveloped world compared to the developed world?
So it's interesting. I've got more senior colleagues who's tell me, and I think I've probably had time enough in the job to observe it myself, that the nature of preeclampsia in high-income countries seems to have changed. It seems to be less virulent than it used to be, especially in well-resourced women. I mean, clearly the indigent poor in North America are similar to many populations in low and middle income countries. So to a certain extent, global health is important for North America as it is for women in low and middle income countries themselves. So the sense is that the more and more preeclampsia that we see in North America is associated with the maternal form of the disease, as Jim Roberts coined it a few years ago, he and Roberta Ness, and that as against the placental form of the disease, which tends to be early onset preeclampsia. So the maternal disease is more at term, it tends to be milder, it's more evanescent. You deliver the placenta, they diurease, they become normotensive pretty quickly, but of course they have put up their hand and said, here's my long-term cardiovascular risk, but so they've declared a biological vulnerability due to their weight, but it tends to be a less virulent disease. But part of that may also be the fact that we provide antenatal care. and so that women don't present to hospital as critically unwell and beyond salvage as often they do in low and middle income countries where that is a real issue. That although the hospitals to which they are admitted perform at a level that we recognize as being excellent care, the women arrive at such an advanced state of the condition that they can't be saved.
So as we look forward in terms of preeclampsia, I was wondering if you could comment where you see both the diagnosis and treatment of preeclampsia going.
Okay, so I have to declare a small conflict of interest.
Sure.
I am a consultant to Alair International, which is one of the manufacturers of one of these diagnostic platforms. So in terms of time of diagnosis, I think most of us know most of the time when we've got a woman with preeclampsia in front of us. So I'm not absolutely certain what the added value is going to be at time of diagnosis unless it helps in that risk stratification ability. And I think there are data from the UK around the Pelican study, for example, which imply in fact that a very low placental growth factor level may actually help you sort more sick women from less sick women. So there may be some added value in terms of PLGF in that context, and I presume the FLIT PLGF placental, so soluble FLIT placental growth factor ratio will operationalize in the same manner. But I think these platforms may be particularly useful when we have a woman with pre-existing renal disease and suddenly her proteinuria level goes up. And is that because she's developing superimposed preeclampsia, or is it just something going on with her kidneys because she's pregnant and the hemodynamic stresses? So I think there may be an added value to those platforms there, or the woman with pre-existing hypertension. And I think we usually know when they've developed superimposed preeclampsia because suddenly they become resistant to antihypertensives, and they'll have a step up in their proteinuria if they had it before, or they'll develop new proteinuria. But to have a test to confirm that suspicion would have clinical utility. I think those platforms may also be useful in terms of identifying other placental conditions from non-placental conditions, the clear example being the suspected IUGR fetus, where we may actually be able to discriminate the placentally small fetus from the constitutionally small fetus just because mum and dad are small. So I think they're the ones that are closest to our practice at the moment, but there's a lot of work on other biomarkers occurring, both urinary and blood biomarkers, and one of these angiogenic platforms is actually going to be going to whole blood on we're using a finger prick and point of care diagnostic, for example. So we are evolving towards being able to refine and individualize care to a greater degree than we've been able to before, which I think is a good thing, because many of the criteria we currently use for severe preeclampsia don't work. They don't operationalize when you actually test them against adverse outcomes, and so we have to become more sophisticated at that, I think.
Finally, Peter, we have so many young people who are interested in both international health and research. I was wondering if you could tell us a little bit about the role of mentorship and how you get started in this particular field.
I happened upon it. I was interested, and I suppose I seized the opportunity when it was presented to me. But I happened to be fortunate to meet a couple of important mentors. Zulfi Bhuttar, who's at the Aga Khan University in Karachi, for example, who's now also at Sick Kids in Toronto. It's quietly sort of taken me and led me into this area himself, and individuals within the institution who have been doing global health in Vancouver, and others just around you. And as you get slightly more exposure to people, so you're meeting people from the WHO, Mario Marioldi, for example, who encourage you, then I've just sort of happened into it, and because I was inclined to, because I realized that that's where the burden of death and damage was occurring. So it's been somewhat opportunistic. I think there are, if I'd had a mentor earlier who could have sort of helped me through those steps and identified those people earlier, then I probably would have started doing this a long time ago. But the story has sort of unfolded in an organic and logical fashion for me. So I'm quite comfortable with how it's happened, and I must confess that the France Donné from the Gates Foundation has been fantastic.
So, Peter, thank you very much for taking the time to be with us. Hopefully our audience will find this to be as interesting as we have.